Let's stop the comparisons and let's start our program on time. Just we are late 1 or 2 minutes, but allow me, to open our meeting, our first plenary meeting of day 2. The name for it is Ending the HIV/AIDS Epidemic, Evidence-Based Approaches and Effective Mechanisms. So the head of the official delegation, I just don't quite understand. I don't understand who is going to be the official head of EECAAC country delegation. Then the floor is given to Samuel Margaryan. We ask you to, since you are the head of the delegation, EECAAC, because that is how it is indicated in our agenda. No, it was Armenian delegation, actually, not. Well, sorry, you're not in the agenda. So I apologize. Okay, it works. Yes, it's just indicated that it's an EECAAC country. Armenia is not mentioned here. So you know what to say, and good morning, dear ladies and gentlemen. I will try, within the time that is allocated for my report, to show the experience of Armenia in ending the HIV epidemic. These are data about Armenia. The population is slightly over 3 million. The territory is 29,000 kilometers, and we're going to speak about this subject. At the end of March 2018, we have 3,003 registered cases. The estimation of people living with HIV is 3,300, and the ratio of HIV is only 0.2%. So that's a very low number for Asia. During the years that we were trying to end the epidemic, we reached very considerable results. We streamlined the surveillance over the epidemic and integrated our work with other agencies. We reduced and stabilized the epidemic among the population and among temporary migrants. The government of Armenia pays a lot of attention to the situation with HIV, and they established the first national program for AIDS in 2002, and this is the fourth program that you see on the screen now, with comprehensive measures to end the epidemic. That includes the migrants. Also, we try to prevent the vertical transmission. We provide care and support to HIV-infected people, and it's in compliance with the UN political declaration, UNAIDS, and in compliance with the strategies of UNAIDS in the European region, and keeping in mind the goals of 2030. During the years of our efforts, we created the legal framework for HIV, and it reflects most of the international documents on HIV and AIDS. We have the law about prevention of HIV and a number of regulations of the healthcare ministry. The regulation of the prevention, diagnosis, and treatment is indicated in the documents. In compliance with the current positions on all the three, we organize the measures to prevent, detect, and cure HIV. We have the operational documents for testing and consultations of HIV-infected people with various degrees of the illness, the sanitary norms, and the provisions for providing medical services, both routinely and comprehensively biologically. We carry out surveillance of the spread of the epidemic, and it's in the program. The country has the universal access for ART since 2005, and in the middle of 2017, in compliance with the recommendations of UN, we adopted the strategy, everyone gets the cure. So right now everyone is treated free of charge at the medical institutions, and this assures that the children are not infected in the families. At the end of 2017, 84 of patients with ART therapy didn't have any identification of their viral load. The access to the comprehensive services to prevent vertical transmission mother-child is established, and we carry out quality testing for ART, and we provide the stability in the funding for these efforts. The prevention of transmission from mother to child is covered from the government budget. Everyone has access to the services, and since 2007, we haven't had a single case of a vertical transmission. The success of Armenia allowed us to file an application for the certificate of elimination of vertical transmission, and we received the mission of the UNAIDS experts to prove this fact. The evaluation showed that the country has reached all the necessary validations to eliminate that vertical transmission and all the target goals of UNAIDS. And in 2015, they confirmed the success of Armenia in eliminating the vertical transmission. And in New York, there was a special event of WHO in June 2016, and we received the certificate validating our efforts, and we received a high appreciation of our efforts to keep up the status of elimination. In the Republic, we have a number of measures to make the donor blood safe. All the donors are mandatorily tested for HIV, and during all the history of our surveillance, there was only one case of blood transfusion infection. In Armenia, also, we didn't have a single case of the nosocomial transfer, and post-contact, post-exposure prevention is also assured. So all the contacts with the HIV patients are under surveillance, and The prep is carried out with the help of ART preparations. We have a system of surveillance over the epidemic of HIV, and we carry out biological and behavioral surveillance over the epidemic, and we also monitor the toxicity of preparations. This is the curve showing that the spread of the epidemic is going down. In Armenia, we created a large staff of people who can who can work to prevent the epidemic, and various institutions are involved in that. We have the HIV and AIDS Center, and we have several training courses for the healthcare specialists and for nurses and sisters, and this is all integrated into the advanced medical staff training in the Republic. In order to provide quality medical services, and in order to prevent the stigma and discrimination related to HIV and AIDS. So we could have enhanced the number of testing in the point of care, and for the people who come to be tested for HIV, and we also developed a training course to train specialists for this inspection. We have a widely spread network of testing. The number of those centers are 58, and the blood is tested in the 10 regions of Armenia, in the capital, in the 58 laboratories which are certified to test for HIV. The HIV and AIDS services in perinatal period are provided all over the country. Pregnant women can receive services in all these centers, and the testing is carried out by various labs within the Ministry of Healthcare. Before 2016, the HIV patients were tested for TB in the TB clinics, but most of them didn't arrive at these clinics. So now the testing is carried out at the HIV centers, and also the treatment is provided there. If it's not enough, then they are sent to the TB centers. Their sputum is tested, and also they have x-rays of the thoracic area, and prevention of TB and HIV infected people is carried out. In this center, they are diagnosed also for virus hepatitis B and C and other comorbidities and opportunistic infections. In the Republican Center, they have a free access to monitoring, and these outpatients clinics, they carry out the tests for CD4 cells, and they monitor the drug resistance to infections. In the latest year, our HIV Centers specialists provided a lot of presentations, poster reports at various conferences devoted to HIV AIDS, and they published over 50 articles in various journals. Within the framework of the Russian assistance, we cooperate with the Epidemiologic Institute of Russia, and we carry out research in compliance with these directions. We receive technical support from UNAIDS, and we carry out regional research and regional surveys about the recent cases of infection, and also we streamline and perfect our mechanisms of prevention of HIV and TB among migrants. Together with the migrants organization, we must confess that the successes of our republic wouldn't have been possible without the international donors. The main of them are the Global Fund and the government of the Russian Federation and the French initiative, 5%, and also UNAIDS and WHO. We prevent the infection in Armenia, and our efforts have been recognized by the Executive Director, Michel Sidibe, and by the head of the WHO. We also received appreciation from Zsuzsanna Jakab, who is the director of the European Regional Bureau of WHO, and also from Bradley Buzeta, who is the permanent coordinator from WHO in Armenia. The Russian assistance in our efforts to end the HIV/AIDS epidemic come from Russia, and we now initiated the second phase of this cooperation, and we hope that this program will be continued because it's very important for us. The main donor is the Global Fund, who's been supporting us financially since 2004. And the grant program of the Global Fund, we receive the highest appreciation from and the highest marks from this Global Fund. Also, our successes were noted by the State Service of the United Nations, and we received an award from them within the forum of the Government Service of the United Nations. We received this award for the first place. We were the winners of the government support competition. We took the first place in the category of innovations and quality in providing the medical services, and this is the certificate for the initiative and the best provision of government services of highest quality within the program of sustainable development. Now I want to dwell on the key tasks and key challenges of reaching the 1999 in Armenia. One of the key challenges is the late diagnostics, which of course affects the efficiency of our treatment and raises the morbidity. A lot of these patients receive diagnosis in the latest stage, but
I need to say that this indicator goes down with each year. Migration, it significantly influences HIV pandemic situation in Armenia, and 70% of new cases of HIV are associated with migration factor. Migration also influences later diagnostics of HIV because migrants have limited access to HIV tests and overall healthcare services, and therefore they go to doctor only in those cases when their health is already in very poor state. Also, migrants influence the efficiency of HIV treatment. Migrants start treatment, then they go away from the country, then get back, and that creates huge risks in terms of insustainability of treatment. And it also makes worse monitoring of treatment. Medical resistance is developing. In order to reduce influence of this factor on the HIV epidemic, it is really important to continue bilateral and multilateral initiatives which will be aimed on developing of the most effective mechanisms of cooperation and the ways when we can reduce or provide the services on prevention and treatment for migrants. The strategy in Armenia, under the name of "to take care of everyone," still faces the challenge of insufficient motivation to start art, and it is key to maintain the art for those who has embarked upon it. Financial sustainability is a guarantee for sustainability of HIV treatment. We need to mobilize internal and external resources, and it's one of the priorities of Armenian government currently. But the main problem here is the reduction of donor sponsorship. Armenian government committed to continue increasing HIV programs, but it's not sufficient in order to cover all the needs in our country. Therefore, our agenda has the items which is called to sustainability plan implementation. We're going to implement sustainability plan on a step-by-step basis. Therefore, we will continue mobilize internal resources and will also use donor funding. And to conclude my presentation, I would like to wish good luck to the conference and all the participants and the speakers, and I hope that the recommendations that will be developed here will contribute to reaching ambitious goals of sustainable development and will be put down in the formal documents. Thank you. Thank you very much for the interesting presentation that you have made, and on our side we also want to wish you be sustainable and using your internal resources, expanding on your internal resources that can support sustainability of the programs that you have launched and are implementing in your country. Thank you very much. I would like now to hand over to our next speaker. This is Professor Abdul Karim, Professor of Clinical Epidemiology at Columbia University, and he is Director of the Center for the AIDS Program of Research in South Africa. And Mr. Abdul Karim is one of the most high-profile international experts in terms of HIV prevention. So he comes from South Africa, and he can give us a good picture of recent achievements in this sphere.
Thank you very much, Dr. Pofrovsky. It's a great pleasure and an honor to be with you here this morning. I'd like to just take this opportunity, in addition to my co-chairs, to say what a pleasure it is to engage in this discussion and to share with you some of the evidence that we think can help end the HIV epidemic. So it's my great pleasure this morning to talk to you about some of the global achievements in HIV prevention. And the way I plan on doing so is to start off with a very brief look at the HIV epidemic at a glance, but then I'm going to talk about the progress we've made with treatment and how HIV prevention is lagging before I touch on some of the achievements we've made in HIV prevention and end off with the UNAIDS 2030 targets and what it means to be talking about ending AIDS. So when we look at the global HIV epidemic, in 2016, there were 37 million people living with HIV, 1 million HIV deaths, and 1.8 million new infections. Now, you've already heard this, but to me, the way I internalize these data is to simply look at this, to look at the fact that there are about 5,000 new HIV infections in the world each day. And that gives us some idea of the magnitude of the challenge we face at a global level. Now, we know that HIV simply does not affect all countries equally. My own country, South Africa, heads up this list of the 15 countries that have the highest burden of HIV infection. So if we look at South Africa alone, 1 out of every 5 people living with HIV in the world lives in South Africa. If we look further down the list at number 14, we see where Russia features on this list. And if we take just these 15 countries, and if we can control the HIV epidemic in these 15 countries, we would be dealing with just about 3/4 of the entire global HIV epidemic. And these data are for people living with HIV. Let's now look at the number of new infections by country. And again, you see South Africa features as the number 1 country on this list. And you can see further down the list, Russia, Kenya, Mozambique, are all the other countries that feature in terms of the number of new infections and where they rank in the top 15 in the world. If we look at the important role that this region plays in assessing the global HIV epidemic, the concerning rise of HIV infections in this region is one that we all need to put some attention to. And if we look at the progress that we're making with treatment and why prevention is lagging behind, we'll get some clues as to what the issues are. So if we look at the total number of people who have been initiated on ART each year, you can see that last year UNAIDS estimated with WHO that there were just over 20 million people on antiretroviral treatment. So this is about 20-odd million people, say 21 million of the 37 million people who are estimated to have HIV infection. So there's no question that we've been doing well. Indeed, the number of people receiving ART globally rose from about 2 million in 2005 to about 21 million in 2017. So this is nothing short of a miracle of amazing magnitude at the global level. But it's not consistent across regions, and this is one of the regions where it is lagging behind. And we need to find the energy and the resources and the effort to do even better, because even with 20 million people on ART, much, much more still needs to be done. And that effort, from what we've already heard now this morning from Emilia, needs to be replicated and even further enhanced. So now that we've got some idea of the success that we've had in increasing treatment, how are we doing in terms of reducing the number of new infections each year? And this is where we see some disappointment. That over the last 3 to 4 years, we've seen a drastic slowing down in the decline of the HIV incidence. The number of new cases is not going down as rapidly as we had hoped. Indeed, UNAIDS had set a target with WHO a few years ago that we would aim for 500,000 new infections in 2020. It looks like that target will remain but a distant dream at this time, because just last year it is estimated we had 1.8 million new HIV infections. So we have to do better with our lagging HIV prevention efforts. But there have been achievements in HIV prevention. So what you have been seeing in terms of the slowing down is not the whole picture, in that we do have amazing achievements across the globe, including in this region. If we look at our toolbox and the evidence that we have for our toolbox of all the different technologies, whether it's behavioral interventions of counseling and testing, male condoms, female condoms, circumcision, whether it's needle exchange, opioid substitution therapy, PrEP, or treatment, all of these technologies have an evidence base that show that we can effectively prevent HIV with these tools. So how are we doing with these tools? How successful are we in, how successful are we in implementing these tools? It's one thing to have the evidence of effective technologies. It's another matter to achieve the goal of reducing HIV, because that requires implementation and implementation to scale. Well, at a global level, we are certainly doing very well in mother-to-child transmission. In mother-to-child transmission, there is a global plan for the elimination of HIV infection in children, and we've already seen drastic reductions in the transmission of HIV from mother to child. Indeed, we already have a plan in place that looks at the global elimination of HIV infection in newborns. And if you look at the impact that these prevention technologies have had at a global level, we have averted about 1.6 million new infections in newborn children since 2000. And that's an amazing feat. And it's been accomplished by all the hard workers, like many of you, at the coalface, in the clinic, in the hospitals, taking care of patients. If we look at some of the other technologies, and I'll talk briefly here about HIV counseling and testing, in several countries, and I've chosen several countries from Africa because that's where counseling and testing was lagging, we have seen drastic increases in the number of individuals who now have access to counseling and testing for HIV. And this increase reflects the accomplishments that are occurring at a community level, but also at a health service level. If we look at the number of people who are reporting condom use at their last sexual intercourse, and these data compare from the year 2000 to 2015, you can see a steady increase in the number of individuals the number of men who say that they've used a condom in their last sex act. And this comes as, not just because condoms are there, it comes because there's a deep political commitment in the region to implement condoms. And here I share with you our president of South Africa introducing new condoms that the state is providing and manufacturing that will now become available. I have to tell you that what he's holding in his hand in the pink packet is a strawberry-flavored condom. So for those of you who have an interest in having a fruity experience, this is the kind of condom we would like to see, and this is what has been introduced into our clinics in South Africa. In case you're wondering, the purple one is grape-flavored condoms. So we are moving to a situation where we want to make condoms exciting, and our president shared this in Parliament, indicating the level of commitment from the highest levels of government to condom provision. And we see this not only with condoms, but if you look at male circumcision, we have seen a steady increase in the number of men who are being circumcised, with just over 14 million over the last several years. And this applies even to people who are injecting drugs. And here we see the proportion of individuals who claim to have used a clean needle in their last injection steadily increasing across several of the countries, including, and you can see right at the top is Ukraine and Vietnam thereafter. We are seeing these kinds of technologies, which have been proven to be effective, now reaching scale. We've got to take that even further if we are to impact on the global HIV epidemic. And not only with clean needles, but also with opioid substitution for those individuals with opioid dependence. I want to just touch briefly now on PrEP, a new technology, the newest of all of the technologies we have, the use of a combination of tenofovir with emtricitabine, what is known in the commercial world as Truvada. The use of this pill a day is very effective in preventing HIV. And now WHO recommends its rollout in groups that are at highest risk. And in this setting, clearly one of the prime targets for this kind of prevention approach would be the discordant partners of HIV-positive injecting drug users. So we have to look at how can we utilize these technologies using the evidence that's available to impact our local epidemics. And at a global level, tracking the HIV epidemic across the different modalities of prevention that we have, there are many organizations doing that, and I've shared with you here what EECAAC, an NGO from the US, is doing in terms of monitoring and tracking how we are doing in terms of each of the 5 key approaches that we are taking in HIV prevention. So let me end off now with touching very briefly on the UNAIDS targets and the UNAIDS 2030 fast-track plan. UNAIDS has already established a 2030 goal of epidemic control. The UN Declaration for 2030 has stipulated a target of a 90% decline in HIV incidence against a baseline of incidence rate in 2010. The UNAIDS 2030 goal is simply to end AIDS as a public health threat. Now, epidemic control can mean many different things. And indeed, as we've tried to measure what epidemic control means, probably the simplest for all of us is to think about getting the disease to a state where it is no longer a high priority and a challenge for our country. But we can also define epidemic control mathematically, and in this instance, using the reproductive rate of infection, that when that rate goes below 1, that we call that epidemic control. In other words, when each case of HIV leads to less than 1 new case of HIV, we regard that as epidemic control. And some suggest that an incidence rate of 1 in 1,000 may be a good starting point for that. The UNAIDS Fast Track report talks about how to embark on a fast track strategy and provides the evidence of how to approach reaching the UN declaration targets. So the ending question that I have is HIV epidemic control achievable without a vaccine or a cure? And the answer to that is, if we look at all of the available technologies, prevention and treatment, there is no question that yes, HIV epidemic control is achievable if we utilize and scale up all of our existing technologies. However, a vaccine or a cure is essential if we are to eliminate HIV, which at this time is not yet the target that we have set. So in conclusion, I think I've given you a perspective of the impressive progress we've made in scientific discovery, and I've shown you the favorable global HIV trajectory with some concerns of recent. We see how this particular region needs to join this growing trend, and there's really no room for complacency. We have to banish this falsehood that the AIDS problem is finished or the AIDS problem has been overcome. We're not even halfway there yet in terms of both treatment and prevention. In this particular region, clearly we need a focused effort on people injecting drugs. And a big concern is about their partners, because the epidemic can then bridge into the broader population. This region simply cannot afford to miss this historic tipping point and risk losing the momentum against AIDS. There are many challenges, but I do not believe they should deter us. We won't end AIDS tomorrow, but it simply has to be part of our long-term strategy. Thank you very much.
Thank you very much for such an informative presentation. And the next presentation is by Stefano Vella, who is the head of the Department of Therapeutical Research and Evaluation, National Institute of Health. And I know that he's a brilliant speaker. I always enjoy listening to him.
I'm glad to be here, and thank you for this invitation. I'm familiar with the EECAAC, and so I'm very glad. And thanks also for giving me a very easy title for my talk, Ending AIDS. What I'll do today is just put forward the problems, not the solutions. I mean, some solutions, but actually the problems we have to put an end at the AIDS epidemic. And I'll try not to repeat what my friend Slim said. Let's say that what's the goal? So the goal we know. The goal is to put an end to the AIDS epidemic by 2030. It's a part of the Sustainable Development Goal number 3, and you see it's here, is a kind of Millennium Development Goal unfinished agenda. So that's our goal, and that's it. This has it's written in the document of the Sustainable Development. So we have to have this goal in mind. Now we need to see if it's achievable. This is what I'm trying to explain today. What are the barriers that I see to this goal? So in a sense, I'll talk about the dark side of the moon. Despite the incredible amount of persons put on treatment, so this is an incredible success of the international community. In the year 2000, when I organized the Durban conference, we couldn't believe that that could happen. But that became true since the next year. And this had, indeed, an impact with a significant decrease of HIV mortality. Of course, this decrease, it's not similar to the decrease we saw in the western part of in the rich part of the world. That was really dramatic, going almost to zero, but still it's very significant. Of course, this is a result not only of the introduction of the antiretrovirals, but also of the prevention, as Slim Karim said. So the two combined had this impact. Despite this success, let me say that, as again Slim said, we still have too many new infections per year. And this is something we need to understand why it's happening. It's still happening. And this is what I'm trying to there is a reason for that, I think. And for example, another issue that it's not really, that is not making me happy is the fact that mortality declined, but not at the same rate as we scaled up art. You see, there is, of course, as I showed you before, a decline in mortality, but it's not so sharp. And the next problem we have is the persistent burden of advanced HIV disease. Yesterday, this has been presented many times, and particularly here, but also in Italy, we have the same problem. Advanced HIV disease presented to our clinics. So why this happens? What are the reasons for this sustained number of new infections and late presentations in our community? So I think that we have a dark side of the moon despite the success. My first message, but Slim also said this, I think we need to say to the world leaders that the HIV epidemic is not over. Maybe we need to rewrite our narrative, saying that it's not the end of AIDS. Maybe it's not even the beginning of the end. Let's say that, as Churchill said many years ago, maybe we are at the end of the beginning. So let's be honest, we are not there yet. There's a long run to go. Now, let's have a look at 1990. It's definitely a very ambitious target to help ending the AIDS epidemic. It was invented a few years ago, and let's see where we are, how close we are to reaching these targets. There is a big variability among regions. You can see from this slide, and unfortunately, the non-EU Eastern European countries are a little bit lagging behind to the targets, but actually, not even the European regions, the EU, Eastern Europe, and Europe and Central Asia are not on target. So we are not on target. Some countries in the world are reaching their targets, but overall, this is a mean. We are out of target. Now, the problems are multiple. The testing, this is where we are really not doing well in many countries. There is a gap in testing. Reasons are multiple. First of all, again, we have like 17 million or 18 million people that do not know that they are infected. That's a big problem. The problem are the challenges in testing. Sometimes these are due to the policies, the stigma and discrimination. People do not like to go to the hospitals and be tested or enter the AIDS clinic to be tested. And so it's a problem also of delivery. We know since years, actually, that a way forward could be HIV self-testing, but as you know, this has not been implemented everywhere, particularly the newest way of doing HIV testing, the home testing. And so you see this slide that I took from ECDC, home sampling, home testing is not implemented, even in the rich countries of Europe. So that's a problem. That's maybe a solution for the future. Then we have the issue of entering care. Entering care is the second 90 where we lag a little bit behind. There are a lot of innovations coming. For example, some are using or trying the test and treat the same day to link the people. Okay, you are HIV positive, then I'm starting the treatment immediately because the new guidelines, WHO guidelines, allow me to do this. And at the recent CROI, there was a presentation of the San Francisco experience. Actually, it worked very well to link people to care. At the same time, if you look at Lesotho, the idea is that it worked only partially. So the test and treat on the same day may work only in some settings and not everywhere. In terms of innovation, of course, this is something we are trying to do in different areas of the world. The first is to integrate care. So it's not only HIV. people come to be cared for other diseases, not only the infectious diseases, but chronic diseases, hypertension, diabetes. So they are invited to come, say, hey, I'll take care of you, not only because you are HIV positive, but I'll take care of you as a person. And of course, this is also something that we are experiencing many, is the differentiated models of care. What does it mean? It means that to give the care in the hands of the patient, because we know that an educated patient community can provide care even better than doctors, even better than nurses, because they are peers. They understand the situation. They understand who you are and what are your problems, so it can counsel you. And this is something we are trying in different areas in Africa and elsewhere. So those are innovations that could help to reach the second 90. Let's go, and these are models that are used. They started in South Africa, but now it's quite everywhere. The client-managed groups, the out-of-facility individual care, etc. Now let's go to treatment. Let me say the treatment that we have now in our hands, the antiretrovirals, work very well. So if something doesn't work, this is not the drugs. Let me say they have been perfected over years. And also there are some coming, very interesting, long-acting drugs, low resistance, high barrier to resistance drugs, very potent, single pills. So let's say that the drugs that we have, they work and they are very good. The problems are different, are elsewhere. Although, you see, when a person starts treatment, at least at the beginning, suppression is reached quite easily and quickly. The problem is not on the drugs. The problem is elsewhere. Look, for example, at the impact of art on HIV incidence. When we use art to decrease incidence as treatment, as prevention, because treatment, as you know, is good per se, is good as treatment, because you save lives, okay? Now, you know, the treatment is also prevention, because it stops transmission. From mother to child, we know it since the 90s. But then we discovered that it's very good to stop transmission for an infected individual to his partner. So we have some good news. This is a trial that shows, and that was also presented at CROI, in Rakai, in Uganda, that in fact, putting together treatment plus prevention, mainly the circumcision, worked very well. Here, this trial showed a marked decrease in incidence. So if you put together treatment plus prevention, it works, at least to a certain extent. We have a prevalence from 41 to 36, so it's not enormous, but it works. We also have less good news. This is a French trial, the TASP trial, where with the test and treat approach versus the usual approach of waiting, the difference in incidence was the same. There was no difference in incidence of new cases. So this test and treat approach didn't work. Maybe because, as the commentaries say, they didn't reach those in the community who are most likely to be the source of ongoing transmission. And that's coming, I'm coming to the point of my talk. We need to reach these guys because, first of all, retention in care over time is suboptimal, we know. Starting a patient on art, it's rather simple if you convince him. Keeping him and retaining him in therapy 4 years is a different story. And all the studies that we know prove that after a few years, people stop taking the pills. So that's one real risky situation because you know that there is no cure yet. So treatment has to be taken forever. And if you say to a young guy of 25 that he has to take these pills for 35 years which is his life expectancy, then it's frightening. Anyway, 2 warnings. First of all, this problem of long-term retention is a challenge, particularly now that we are treating the asymptomatic patients. Asymptomatic patients, for those of you that are involved in clinical care, you know that it's difficult to keep them forever on treatment because they say, hey, I'm okay. Why should I take this pill forever? And so that's one of the problems. And remember that non-adherence brings resistance, which is expanding in Africa. Anyway, this is a warning. Now, let me revisit 1990 to see how we can perfect it. So let me say this, first of all. First of all, I think it's a great idea. 1990 is really a great slogan for this reason, because in a sense it fosters universal access to care and treatment, it provides operational advantage, and contribute to equal global equity. So to foster treatment and to have people on treatment for its own benefit, I think is a great idea. However, you know, this is the schema of the 1990. And at the end, the target is that we need to have 73% of all infected patients fully suppressed. That is the basis of the model. And the model says that if you can have 73% of patients fully suppressed, then the epidemic will be stopped. The flow of the virus will be stopped. However, so it's the concept of herd immunity. You know, many of you are infectious diseases. You know what's herd immunity. You mean if you vaccinate your children and you have a coverage of 90%, then the virus do not pass into the community, 90, 80%. And that's the same concept of herd immunity was translated from the susceptibles to the transmitters. So the idea was smart. However, let me say that this is a problem. HIV transmitters are not an homogeneous population like the recipients of a prophylactic vaccine. Your kids are all the same. They all respond to vaccination. If you turn the story around and you want to stop the transmission from the transmitter, you need to understand that transmission dynamics are HIV transmission dynamics is very complex. And it's a result of interaction from HIV viral load, the higher the worse, and the number of transmission events and transmission efficiency. So if you factor these two, you can understand that the transmitters are not the same. An IV drug user has a transmission efficiency of 100% because he just shares the syringe, 100% transmission. A man having promiscuous or a lot of sexual intercourses, of course he multiplies the events. So he's not the same like someone that doesn't have these two. And you know that viral load is high generally in late presenters like the key populations. So what I'm scared is that treatment alone, only pills will not be able to curb the epidemic because the 27 left behind of the factor are most probably the hard-to-reach, stigmatized populations that drive the infection of HIV in the world. And also they include probably the acute infections. You know that acute infections deals for 50% of new infections? So that's a problem. Anyway, this is what the message. The message is that if we don't reach the key populations, then treatment as prevention will not work. Key population includes IV drug users, sex workers, incarcerated people, MSM, the exploited young women, and MSM. And the problem is this, that key populations are at high risk of progression to AIDS, generally because of lack of access to art, or very late presentation, because then when they are sick, they come, of course, but they come late, only when they are sick. And are also very likely the drivers of HIV transmission. So if we do not focus our attention on their needs and on their impact on HIV transmission, then it will not work. And this is, I think, one of the reasons why, despite the number of people on treatment, we still have a high number of HIV transmissions and infections, because this is driven by the key populations. And PrEP, of course. PrEP is, in a sense, let me say, is our vaccine. Is our vaccine. In the absence of a true vaccine, PrEP is the weapon to protect the key populations to get infected with HIV and then transmit it again. Don't speak about prevention because Slim did a fantastic talk on that. Just to say two small messages, and I'm going to the end. First of all, remember the diversity of the HIV epidemics. Intervention shall be very targeted, even the prevention. And as I said, and as Lynn said, new prevention tools and technologies gives a lot of hope. PrEP works, circumcision works, microbicides and works, at least partially, and harm reduction works. Be careful. I'll show you something from Italy. We had our epidemic started with HIV drug users. We had, I have some Italian friends here, we had at the beginning 75 or 78% of all our HIV patients that were acquired infection through IV drug use. Look at this. You see on the left, before 2005 we had 60% of IV drug users, then, and very few heterosexual transmissions. Then the epidemic, because we didn't control enough, we didn't help our IV drug users, the epidemic turned to the general population very quickly. Be careful, when you don't control the infection in IV drug users, you do not do your harm reduction, then the general population will be hit. And finally, tomorrow you will have fantastic talks on vaccine and cure. My personal view, but my personal view, is that we have never ended a global epidemic without a vaccine or a cure. And HIV will not be an exception. We can control it, but if we want to eliminate HIV, we need a vaccine or a cure. And here we have Sharon, that tomorrow, will talk about the progress. You know, there's been progress. I don't want to go into this, but there's been progress both in prophylactic vaccination, we know how to induce neutralizing antibodies, and in attempts to cure it, or at least to have lifelong remission without drugs. So these two targets are, I think, in the horizon, and I think we need them together with the drugs. You know, I'm a clinician, I work with the drugs, so I love art and antiretroviral therapy, but I think that we need to use it properly and focus on key populations, and we need to work also on other prevention methods. Thank you very much.
Dr. Vela, indeed, you've shared with us some deep insights into some of the big challenges that we face in treatment and certainly in bringing an end to HIV. So it's my pleasure to introduce our next speaker in this session, where we are looking at evidence-based approaches to ending AIDS. And I'm going to be introducing very briefly Professor Chris Byrer, who is the Desmond Tutu Professor at the Bloomberg School of Public Health at Johns Hopkins University. And we indeed are honored to have a person of his stature, because not only has he been the president of the International AIDS Society, but he's one of the global leaders in our attempts to control HIV. Over to you, Chris.
Thank you so much, Slim, and good morning, everyone. I want to thank the organizers for the opportunity to speak to you all. It's been several years since I've been in Russia. It is wonderful to be back and wonderful to see our many dear friends and colleagues. What I wanted to talk with you about today is some updates on the epidemiology of HIV, and the epidemiology both in this region and in this country, but also a little bit about the uses of epidemiology to drive decision-making and to drive public policy. I'm going to do that with a focus on key populations, and then specifically looking at some of the data that has been made publicly available thanks to Professor Prokofsky and his colleagues. I think they really need to be applauded for that openness. And then a little bit about some of the responses. Indeed, yes. Some of the responses that come out of those data. So you heard from Slim about where we are in the epidemic, and I have to go through the English here with the with the Cyrillic. It's going to be a little tricky. But of course, we have had 39 million people already die in the context of this epidemic. We have had a number, over 1 million deaths in 2016. We still have 36 or 37 million or so people living with HIV. In 2016, the last data we have, last year we have data for, as you know, we still had a very large number of new infections, over 1.8 million. That number would be higher if we had better estimates from some of the countries that are really challenged with new infections. We do have more than half of people now. Is this advancing? Oh. Yeah. We do have more than half of people now on treatment, and we are beginning to see finally a global PrEP implementation. I'm not going to talk about those issues so much, as I do want really to focus on this region. So in Eastern Europe and Central Asia, the most current data from UNAIDS are up through 2016. Many of you will have seen these data were released on World AIDS Day last December. And unfortunately, what we saw was that new HIV infections continue to rise in this region. They have risen 60% between 2010 and 2016. That is really an outlier in the global epidemiology of HIV. But it's not just new infections. There also has been increasing AIDS mortality. So treatment coverage remains very low. 28% is the overall estimate. The range is 22 to 32%. And of course, with that many people living with HIV and untreated, AIDS deaths continue, and they are also on an increasing trajectory. They increased 27% between 2010 and 2016. So that is not the direction we want to go in. This is not, I think I might be losing battery here. Wow. So when we look globally, we see a very different picture. You've seen this from other speakers this morning, declining AIDS mortality as treatment rolls out. And of course, what that also means is when you have declining mortality and ongoing new infections, rising prevalence. So keep that in mind, because that is really what global AIDS looks like in most of the world. But of course, unfortunately here, what we have been seeing, as I said, is rising rates of new infection. This is from the UNAIDS GAP report. And it is unfortunately the case that this is one of the two regions in the world where new infections are continuing to rise. The other is the Middle East and North Africa. So there's two regions where there's an increase. So what can we say about these data? What is this telling us? Well, the first thing has to be said is that these kinds of data should drive policy. If the epidemic is going in the wrong direction, then we need to think about our responses and what we're doing, right? Collecting these data and analyzing them and reporting them and sharing them at a scientific conference is not sufficient. What is sufficient is taking these data and driving public policy. The second thing to say certainly is that if treatment programs were working, AIDS mortality should decline, although HIV prevalence will increase. That is not what is happening in this region. If prevention programs are working, new infections should decline, and as you've seen, new infections have increased by more than 20%. And finally, where we see this combination of rising AIDS mortality and rising rates of new infection, we can say very clearly this is not an epidemic coming under control. So that is really a challenge for us. And I think it's fair to say that a lot of the reason why that picture is happening is because of what you've heard earlier and yesterday as well, which is the challenges of addressing HIV in key populations. And I will just say one, I think, really essential thing about the definition of key populations. It is not just that these people have high risk or high burden of HIV infection. What makes them key populations in HIV is also that they have high barriers and lack of access to essential HIV services. That is critical, right? And that's the part that we, as public health people, as physicians, as people involved in the HIV response, can really do something about. So I just want to say that when you look at the epidemic in my country, the United States, this is now very much an epidemic also that is primarily in key populations. This is the most recent data from the US CDC. That's the group that does our HIV surveillance. And more than 2/3 of new infections are among men who have sex with men. That's the very top curve up there. And you can see, happily, that our epidemic among both heterosexuals and people who inject drugs is actually in decline, but our epidemic in gay men continues apace. So this is also very much a theme from the United States, and it's one that we are struggling and having real challenges addressing. Now, let's talk a little bit about the current epidemiology in Russia. And as I said, the analysis that I'm sharing with you now is from data that were made publicly available last summer. We were able to get that data translated, and I worked with colleagues in our group and also with colleagues here and with Professor Kozachkin. And what did we find? Well, I think, first of all, several things relating to HIV epidemiology. So this is new infections. In 2017, Russia had the largest number of HIV-infected citizens in Europe. The cumulative diagnoses, now over 1 million, 1.16 million, and that certainly is an underestimate. We know that. Cumulative infections in 2016 were over 100,000, so 103,000, which is indeed a very substantial number. That is an increase over 2015, although it's a slightly lower increase. The 2015, 2014, and 2013 increases were even greater. But still, this is an expanding epidemic. Now, I should say this is not precisely incident infection. These are new HIV diagnoses. But nevertheless, they continue to increase. And I think it's important to say that the level now in the population is really getting into very concerning levels. So, for example, Russian men, this is all men aged 30 to 39 years of age, 2.8% or so are living with HIV infection. That is very high. What about AIDS? So from January to June, so that's just the first 6 months of last year of 2016, there were reported over 14,000 deaths due to AIDS. That is a 13% increase over the previous 6 months. So that is rising AIDS mortality. And actually, Dr. Pokrovsky and his colleagues have published on the demographic impact now of that rising AIDS mortality. This is now a major cause of premature death in the Russian Federation. When we look at these data, and what we've done here is essentially take the cumulative diagnoses through the end of 2016 and then put them on a map. This is what's called a heat map, and the darkest color is the regions with the highest cumulative number of infections. By the way, it's not easy to get Russia, the world's largest country, on a slide, so I apologize if it's actually a little distorted there. But these reflect basically reported infections from the beginning of the epidemic, and this is informative data. But I think what's more informative is to look at this. So these are now new diagnoses. It's not exactly incidence, but I think a proxy for incidence. New diagnoses in the last year through 2016. And what you can see is that it's a very different map, and there is a marked concentration. The darkest colors there are really in eastern and western Siberia and in the Urals, right? And that is a very different epidemiology than I think we have been accustomed to thinking of when we think of cumulative infections. This is the same data, but just presented now as a bar graph, and looking at the most affected regions. And actually, in terms of new diagnoses in 2016, the most affected region was the Kemerovo Oblast. But you can see that, for example, Irkutsk is here, a number of regions in Siberia. And we have to ask ourselves why that might be, and certainly the epidemiology of opiates and of opiates and heroin trafficking into the Russian Federation plays a very important role because, of course, this region, unfortunately, has as its southern neighbor Afghanistan, which is by far now the world's largest producer and exporter of illicit opiates, including heroin. And this is from the World Drug Report from UNODC, and what you're looking at is their analysis coming from the opium poppy zones, which are here in Afghanistan, and traveling, for example, up into some of these most affected regions. The epidemiology of opiates, unfortunately, is really quite a good fit with the epidemiology of HIV. So let's talk a little bit about some of the other key populations. And here I will show you some data from our collaborations with Open Health Institute and with, Open Health Institute and AIDS InfoShare. This is an evaluation that we did in 3 regions of the Globus HIV prevention program for women who sell sex, for sex workers. It included qualitative and quantitative work with about 800 women. We used respondent-driven sampling and then a social behavioral survey and HIV testing to understand the epidemiology and also to assess the impact of the Globus prevention programs for sex workers in these regions. These are some of the data from that assessment, and you can see overall, actually, the HIV rate, which is down at the bottom here, was only about 4%, which is relatively low, and we did find a very high exposure to the Globus program, so this was encouraging. But what we found is, of course, lots of people belong to more than one key population. A little over 10% of these women had a history of injection drug use, and another 10% were active injectors. And the HIV rate really differed quite dramatically. So among all the women who had never had a history of injection drug use, the HIV prevalence was only about 1.5%. Among women who were active injectors, it was about 16%. And the really encouraging thing, and the reason I'm showing you this slide, is that this is the comparison here is Women without a history of injection drug use in tan is women who had a history but had recovered, and then these are active users, is that women who had recovered and were no longer using had risks that were really quite similar to women who had never used. So this, I think, is one of the reasons why we have to remember that drug treatment works, and it can have a dramatic impact on reducing risks, even for people who are really at quite high risk. Among men who have sex with men, this was an analysis we did for a Lancet series a couple of years ago. The reported prevalence in this region at that time overall was about 6% of men who have sex with men having HIV infection. We really wanted to look at this in detail, particularly in Russia and in Moscow. So in this city, again, working with AIDS InfoShare, funded by the U.S. National Institutes of Health, we did a large epidemiologic and prevention project in Moscow. This was the Be Safe project, and we recruited over 1,500 gay and bisexual and other MSM in the city in an LGBT-friendly clinic space, the Sanam Clinic. The HIV prevalence, the crude prevalence, was over 15%, so more than twice as high as what had been reported internationally. And when that was RDS adjusted, which you need to do, was still about twice the reported prevalence at about 12%. These are the data from the respondent-driven sample, and I'm just showing this to you to say that even though we only had one clinic and we were using this innovative epidemiologic sampling approach, it really does map essentially the entire city. And so we feel that we did get really quite a representative sample of what HIV looks like here. I won't go into all the detail, but I wanted to share this with you because we've been talking about the 90-90-90 targets. We've been talking about the importance of early treatment and the treatment cascade. This is the data just on these men living with HIV infection. So it's about 220 of the 1,500 were HIV infected. And what you can see right away is, first of all, a number of them had been tested, but mostly in the distant past. Very few of these men were aware of their HIV infection status. Fewer still were on treatment, and when you get all the way down to what proportion of them were virally suppressed, it's only 3% of the men living with HIV. Now that is just extraordinarily low in a country with universal access and free ART. It underscores, I think, this enormous challenge with trying to do better for people from key populations. And it also speaks to what Stefano was saying, and Slim as well, which is that level of viral suppression in a population is not sufficient to contain HIV spread, right? This is a comparison among people who inject drugs, so I want to turn to for a moment that we did for a Lancet commission in advance of last year's, of the 2016 UNGAS, the General Assembly Special Session, which was the first time in a generation that the UN was taking on the issue of drug policy. This is comparing people who inject drugs to reproductive age adults, and you can see pretty much across the board the extraordinary burden that these people bear. And this is looking at ART coverage among people who inject drugs living with HIV by region. And what you can see, unfortunately, is that, as I said, it's not just that they have a high burden of disease, it's also that they have such extraordinary low coverage of services. And you can see the Eastern European, Central Asian region here is among the lowest in the world in terms of ART coverage for people who inject drugs. And that is an enormous challenge, and I think that that goes a long way to explaining why the epidemic here is still expanding and mortality is still rising. So what are the responses that might really help turn this around? What can be done about these very challenging issues? Well, I think WHO, and I know Gottfried Hernschel was here, we really have to thank them and acknowledge that this is a beautifully simple recommendation from WHO, which is essentially that people living with HIV should be treated. And if we embraced that and did better with that simple, it's easier said than done, but that approach really will be the beginning of both declining AIDS deaths and declining new infections. Combination prevention is a critical part of reducing the new infections. I'm going to talk to you a little bit about what that would look like for drug users. And to do that, I want to talk a little bit again about the United States. So we have had, as some of you may know, for many years, a federal ban on funding for needle and syringe exchange. States were allowed to do needle and syringe exchange if they wanted to pay for it themselves, and cities were allowed to do it. In my city, in Baltimore, we had a great program, and the city paid for it, but the federal government wouldn't pay for it. In the state of Indiana, where Governor Mike Pence, now the vice president, was previously the governor, the federal ban was in place, but in addition to that, the state refused to do needle and syringe exchange, and there were enormous barriers to treatment for people using drugs, and the outcome, unfortunately, was an explosive epidemic of HIV in 2015, so years after we had achieved control in other parts of our country, and this was widely reported outbreak in Scott County. I'm showing you on the other side recent outbreaks from Greece and Romania, just to make the point that when essential services are interrupted, in this case due to a financial crisis and due to changes with the Global Fund funding mechanism, you can see these explosive outbreaks among people who inject drugs. So with Scott County, we were asked by the New England Journal of Medicine, myself and our colleague Stephanie Strafty, who's also done a lot of work in this area, to make recommendations to both the medical community in Scott County, Indiana, and to the government there about what they could do to respond to this very severe outbreak of HIV among people who inject drugs. And this is from the paper, and this is what we put forward. So first of all, for physicians and providers, it's very important that everybody in this kind of outbreak setting screen for substance use. Right? That was not routinely happening. Test for HIV, for HCV, and for STIs. That also had not been happening. Offer immediate therapy for HIV. That is critical, including, of course, for people who are active users. If you exclude people who are actively using opiates or other illegal substances from treatment, you may think somehow that you are protecting against, for example, drug resistance or problems with adherence, but that will, in a way, ensure perpetuation of the epidemic, right? So they needed to move to immediate therapy, irregardless of substance use level. To get naloxone out to the community and address the overdose epidemic, which was also happening. To get drug treatment on demand. This was a state where there were long waiting lists for drug treatment, and that needed to be fixed right away. To get licensed, to encourage more people to get licensed and competent in the use of medication-assisted therapy for opiates, including methadone and buprenorphine. To provide needles and syringes, or at least refer people to harm reduction services, and to join the movement to press for law reform. For the government, what we really asked them to do was, first of all, to legalize needle and syringe exchange in the state. It had been a felony with 3 years imprisonment for having a syringe without a prescription. That needed to change, and also to dramatically increase funding for drug treatment and for HIV treatment. I'm happy to say, I don't know that our article necessarily changed the policy, but this outbreak and subsequent ones like it finally led in the United States in 2016 to the lifting of the federal ban, and we now at last can use federal dollars for harm reduction and for needle and syringe exchange in the United States. It's been a very long time coming, but nevertheless, I think it's really essential. It's a shame that it took a bad epidemic to do that, but sometimes, as we all know, that's how it is. I want to just give one more example of a tremendous response for key populations, and this is from London, from the UK. The UK, I think, is a good example of what happens when you really primarily do treatment and not effective prevention. So what you're looking at here is their epidemic in gay men, And it was going up steadily with increasing infections all the way through the treatment era. And the UK is another country that has universal access. It had very good coverage. Over 85% of people living with HIV in the country were on treatment, and still that epidemic was rising. And now there has been a sharp decline, at last, a decline in new infections among men who have sex with men in the UK. So what happened there? Anybody know the answer? PrEP, all right? This is the beginning of the PrEP rollout, which really had an enormous impact. So I just want to say that all the work that we've done here over the years and our collaborations, which have been really one of the most rewarding scientific engagements of my career, are available. We always try and publish in the peer-reviewed international scientific literature. These are just an abbreviated list of this work, which I would encourage those of you who are interested to read in more detail. And let me just end by thanking a number of colleagues at Hopkins, also a number of people who've helped with these data and this work, Professor Kazachkin. And I also want to say a special thank you to my AIDS InfoShare colleagues. For those of you who don't know, although I think most of you do, they are also the secretariat for this conference, and they always do a spectacular job. But it really has been wonderful years of collaboration. So, spasibo bolshoy.
Our last speaker in this session is going to be Wesley Kreft, and one of the big challenges we face in dealing with the HIV epidemic is about ensuring that we have good supply chain management. So we are very pleased to have with us here the Director for Global Supply Chain at the Partnership for Supply Chain Management, is going to tell us about international best practices. Over to you, Wesley.
Good morning. So first I would like to thank the organizers for allowing me to speak to you here about some of the international best practices in the procurement of HIV/AIDS medication. So just very briefly about PFSCM. I work for an organization, it's called the Partnership for Supply Chain Management. We are, among others, the procurement service agent for the Global Fund. And you can read out our mission. Our main mission is to help out and strengthen public health supply chains through innovation, quality, and best value procurements and logistic services. So there are a number of elements that of services PFSCM is offering. So that's from planning, forecasting, quantification, sourcing, making sure that the most advanced medication is being bought, and some of the other elements here like move, quality, and others. So in today's presentation, I would like to cover a number of things. So first of all, the importance of following the latest WHO guidelines, the use of fixed dose combinations versus monotherapy, the advantages of leveraging international contract power to achieve best prices, and some models on how to use managed services as an outsource to your program. So first of all, I think this is all very familiar, but WHO publishes on a regular basis new guidelines, both for treatment and diagnostics. New guidelines will be made available around the International AIDS Conference in July, and there will be some innovative things that will come up in those new guidelines. So the current first-line treatment, it's one pill a day treatment of tenofovir, lamivudine efavirenz, or tenofovir emtricitabine efavirenz. I think WHO stresses in these guidelines very clearly that there's a strong preference for a one pill a day regimen, combining as a fixed dose combination. The new guidelines, and I just came out of Geneva this week, will most likely include the dolutegravir in combination with tenofovir and lamivudine as a third preferred first-line treatment for HIV/AIDS patients. So just a little bit, because I've been attending a number of sessions here, and there were some debates about the use of fixed-dose combinations versus monotherapy. And from our end, it's very obvious that there are huge advantages to use fixed dose combinations, primarily to improve adherence, reduce resistance among patients. From a supply chain perspective, it significantly reduces supply chain costs, for example, in warehousing, distribution, both upstream and downstream. It has shown to significantly reduce the expiries, and I will show you in the next slide, it has a huge advantage in commodity prices by buying a fixed dose combination versus monotherapy. So that's the other international best practice. Try to utilize negotiation power established across different countries. So this table shows you just a number of prices. For example, the currently first line, tenofovir, lamivudine, efavirenz. The contract price, the maximum contract price we currently have is $90 for a full year treatment per patient. Similar prices have been negotiated now for the new dolutegravir combination. So also that one is around $90 per person per patient. Realizing that in some countries there might be some patent restrictions, but I think the overall HIV community have been quite successful in overcoming and trying to maneuver around certain patent restrictions to make products available at affordable prices. So then just briefly on how governments, cities and programs can benefit from external expertise in utilizing managed service providers. I think this is a general statement that across many sectors, industries, outsourcing can yield great benefits, both to the private and the public sector. And I think, especially in the private sector, outsourcing services is a well-known concept and a well-accepted concept, among others, to free up human capacity to actually focus on the important things, to generate significant cost savings, both in operating cost but also in overhead cost. It generally improves the performance of complex operations, and it creates a number of down the line advantages, among others having access to the latest innovations and having not needing the expertise on all the latest things within your organization, but actually having that at an external party. If we specifically zoom in on procurement and logistics advantages of outsourcing, one very obvious one is the pooled procurement to leverage negotiation power. I think by being part of both the PEPFAR program and the Global Fund program, it has shown that by using the volumes across multiple countries, the manufacturing industry is willing to reduce prices and actually offer much lower prices across the globe to all countries. It helps navigate regulatory environments. How do we benefit from best practices in other countries, and how can that help programs in individual countries? It can act as an intermediary between governments and suppliers. There's sometimes some friction between the two, so a third party can be a deal breaker there. Very important, it ensures best practices to globally best practices. A service provider can act as an advisor or a partner to a government. On the logistics side, it gives access to supply chain visibility platforms. I have one or two slides about that in a near time. And it helps the integration of supply chains across different disease areas. I think we are still thinking a lot in silos, and it's important that integration is happening across different diseases. Let me see if this is still... So just a number of layered approaches that are possible. For example, negotiating framework agreements, leveraging already negotiated framework agreements. That's one of the services that you can easily tap in. Strategic sourcing. If you have specific products or even local suppliers and you would like to get them qualified or get the products to the market, that's a service that can be offered. Run competitive tenders. Manage the whole procurement and logistics, but also technical assistance to improve the capacity of in-house services. Another managed service solution is the deployment of a control tower. The nice thing about a control tower is it provides one version of the truth, comparing the demand side, the planning and the supply, with a very unique capability to run specific alerts on irregularities within the supply chain, and it can easily figure out where issues might arise. So some of the things that harness critical information within a supply chain, within a control tower, it reduces supply chain cost. It allows for data-driven decisions versus guesswork. It reduces the inefficiencies and it avoids risk. It allows for automated processes versus human interventions. It established the foundation for serialization and eventually blockchain that ensures end-to-end supply chain custody from supplier up to the patient. So that leads to the, let me see if we can get that one on the screen. Yes, that's the last slide. So within a particular country setup, implementing a control tower within individual countries can usually benefit. It has shown to reduce tied up stock capital, because giving more insight on where stock is can actually reduce the number of buffer stock needed for a program. It provides early alerts on shortages. It gives visibility into improved accountability and data-driven decision-making. And it allows for better product and logistics contracts. And eventually it gives full chain of custody that allows quickly shared data among multiple shareholders. So with that, I would like to thank you, and please reach out to me or any of my colleagues if you have any
Thank you
further
very
questions.
much. But our decision that there will be no discussion after the plenary session. But if anybody have question, you have the possibility to come to the house and to speak with you. Thank you very much. So we are, к сожалению, мы закончили.
Unfortunately, we are wrapping up and we are already behind the time. We already exceeded the allocated time, so we don't have time for any discussion, but the discussion is sort of there. Dr. Abdul Karim and Stefan Weller, they argued a bit whether we can end the epidemic without vaccine or new drugs. There was a sort of discussion, or can we only use the available means of ending the epidemic? But I think that we'll continue our discussion during our next sessions. But it was really a very interesting question. And of course, Dr. Bayer, I was really moved by this presentation, because I think I need to fly immediately to Washington and tell them about the situation in the United States now. And of course, our final speaker provided a very important information, not about the epidemics, but about the prevention measures and achieving these measures that we're all facing. Thank you very much, and see you later in other sessions.